Welcome and good morning to everybody. Today I will start a very important chapter for anesthesiologists, that is essential hypertension and anesthetic considerations. Essential hypertension is a common problem from many people suffer from elevated blood pressure, defined as systolic BP more than or equal to 140 mm of mercury, or diastolic blood pressure more than or equal to 90 mmHg. Of these, 63% are unaware of their hypertension. 45% are receiving treatment, and only 34% are under control using a threshold of 140/90 mm mercury. Proper perioperative management is essential in anesthetic practice. General principles. Definition. Essential hypertension. No secondary cause for hypertension can be identified, such as pheochromocytoma, hyperaldosteronism, Cushing's syndrome, renovascular hypertension, and aortic coarctation. Second point is that essential hypertension comprises 95% of all cases of hypertension. Complications. Uncontrolled hypertension, defined as systolic blood pressure more than 180 mm of mercury and or diastolic BP more than 110 mm of mercury. Classification of hypertension. Blood pressure classification: systolic blood pressure, diastolic blood pressure. Normal is less than 120, systolic less than 80, that is diastolic. Pre-hypertension, that is 120 to 139 systolic and 80 to 89, that is diastolic. Stage 1 hypertension, that's 140 to 179 systolic and 90 to 99 diastolic. Stage 2 hypertension, that is 160 to 179 systolic and 100 to 109 diastolic. Stage 3 hypertension, that is 180 to 2009 systolic and 110 to 119 diastolic. Stage 4 hypertension, more than 210 systolic or more than 120 diastolic. Risk factors for essential hypertension: increased age and excessive dietary sodium intake. Genetic or family history, obesity, alcohol consumption of more than 2 drinks per day, tobacco use and stress. Perioperative considerations for uncontrolled hypertension. Delay the elective surgery in case of uncontrolled hypertension or existing target organ damage that can be improved or should be evaluated further. Increase or modify the antihypertensive therapy. Consider adding beta-adrenergic antagonist. For emergency surgery, consider invasive monitoring of perioperative hemodynamics, that is arterial line and central line. Now, delay the elective surgery in case of uncontrolled hypertension or existing target organ damage that can be improved or should be evaluated further. Increase or modify the antihypertensive therapy. Consider adding beta-adrenergic antagonist. End organ damage like cardiovascular, coronary artery disease, cerebral vascular disease like transient ischemic attacks, ischemic strokes, or peripheral vascular disease, left ventricular hypertrophy, congestive heart failure, retinopathy, kidney failure, neurology, that is hemorrhagic stroke, hypertensive encephalopathy. Perioperative considerations for patients with end organ damage. Detailed preoperative assessment with a focus on end organ damage should be performed in any patient with essential hypertension. Appropriate referrals should be made and the patient's medical condition optimized prior to elective surgery. Treatment and management. Lifestyle changes, weight loss, moderate alcohol consumption, smoking cessation, reduced sodium intake. Pharmacology like SACE inhibitors, beta-adrenergic antagonists, thiazide diuretics, calcium channel blockers, angiotensin receptor blockers. And this brings me to the end of this session. The next part will come with the next video. Thank you.